Okay, let's unpack this. Today, we are attempting a deep dive into one of the most structurally complex and clinically critical areas of the entire human head.
We are. We're talking about the nose, the nasal cavity, and the paranasal sinuses.
And our mission here is really to give you a detailed, three-dimensional mental map of this whole region.
We're moving far beyond just, you know, breathing or what it looks like on the outside.
Absolutely. Think of the nose as this specialized entrance to the whole respiratory system.
It has vital jobs. It has to warm the air, humidify it, filter it.
All while housing the incredible machinery for your sense of smell,
And structurally, you've got the external nose, which leads into the internal nasal cavity.
which is that big chamber divided by the nasal septum.
Exactly. And it opens out the back end of the throat, the nasopharynx, through openings we call the choanae.
Okay, but before we go any further inside, we have to talk about terminology.
We do. This is a crucial point the source material makes. There's a real divide between the anatomical terms and the clinical terms.
Right, like with the conch.
Precisely. An anatomist will say concha to refer to the bony shelf itself. That's it.
But a surgeon.
A surgeon in the clinic will almost always say turbinate. And that term includes the bone, plus all the soft tissue, the mucosa, the blood vessels, everything they actually see and work with.
So concha is the skeleton, turbinate is the functional living structure.
You've got it. Keeping that in mind will make everything else much clearer.
Okay, so with that sorted, let's start on the outside. The external nose, it's basically a pyramid shape on the midface.
It is, running from the root up by the forehead down to the tip or the apex.
And the skin covering it isn't uniform at all, is it?
Not in the slightest. It's quite thin and mobile over the upper bony part, the rhinion.
But then it gets thicker.
Much thicker, down at the tip, and it's more stuck down, more adherent. That's because it's packed with sebaceous glands right there.
And deep to the skin, it's layered like an onion.
It is. You've got 4 soft tissue layers. There's a fatty layer, then a fibromuscular layer.
And that fibromuscular layer is the important one, right?
It's key because it's directly continuous with the SMAS of the face, the superficial musculo-aponeurotic system.
So the muscles that move your nose are tied into the same system that controls your facial expressions?
Exactly. It's all one dynamic sheet.
Fascinating. So what about the actual framework holding it all up?
It's part bone, part cartilage. The bony opening is the piriform aperture, but the most important structural point is what we call the keystone area,
Why is that junction so critical?
because that's where a huge bony part of the septum, the perpendicular plate of the ethmoid bone, it actually slots into the underside of the nasal bones.
It interlocks with them.
It interlocks, yes. And that connection provides the essential support for the entire bridge of the nose. If that keystone fails, the whole thing can collapse.
That's some serious engineering. And then below the bone, we get to the cartilages.
You do. The paired lateral nasal cartilages, which are triangular, and then the very complex major alar cartilage that shapes the tip,
And the way those two meet defines something incredibly important.
the internal nasal valve.
Yes. This is the narrowest point in the whole airway, isn't it?
It is. It's the flow-limiting segment.
Mm-hmm.
The angle there is typically only about 10 to 15 degrees.
So a tiny bit of swelling there.
Causes huge symptomatic obstruction. You can feel completely blocked, even if the rest of your airway is wide open. It all comes down to that valve.
Okay, this is where it gets really interesting for me because the nose isn't static, it's dynamic. It has muscles.
It does. Tiny ones.
I know the procerus muscle pulls the eyebrow down when you're concentrating, but what about the ones around the nostril?
Ah, those are the crucial ones, the depressor septi and the alar part of the nasalis muscle.
And they do something amazing, don't they?
They do. Their action is anticipatory. They contract just before you inhale.
So they're getting ready for the breath. Why?
But to prevent collapse,
Mm.
when you take a fast, deep breath, the negative pressure created can literally suck that narrow internal nasal valve shut. So these little muscles fire off a split second beforehand, pulling the valve open to resist that collapse. It's a reflex arc that's actually linked to sensors in your lungs.
So your lungs are telling your nose how to prepare for the incoming air.
Relentless efficiency. That's a perfect way to put it.
Okay, let's move inside. The internal nasal cavity itself.
It's an irregular space, wider at the bottom, divided down the middle by the septum.
And it runs all the way back to those choanae we mentioned, leading to the throat.
Correct. The floor is pretty simple. It's smooth and concave, mostly formed by the roof of your mouth, the hard palate.
And the medial wall is the septum itself. Part bone, part cartilage.
The posterior parts are bone, the vomer, and the ethmoid plate. But anteriorly, you have that quadrangular septal cartilage.
And that anterior cartilage is vital for tip support. Surgeons have to be so careful with it.
They do. Taking too much can cause the whole tip to drop.
Yeah. Let's look up. To the roof. This is where it gets a bit scary.
It is. The central part of the roof is the cribriform plate of the ethmoid bone. It is incredibly thin.
And it's full of tiny holes.
Perforated, yes, to allow the olfactory nerves to pass straight through from the nasal cavity into the anterior cranial fossa.
So you're saying there's just this wafer-thin piece of bone separating your nose from your brain?
That's exactly what I'm saying. It's the ultimate danger zone in surgery,
I can imagine.
which is why the source highlights a key surgical rule. When you're operating near the cranial base, you always want to work from back to front, posterior to anterior.
Why that direction specifically?
Because the cranial base is actually highest at the front. By starting lower down in the back, you create a safer trajectory and reduce the risk of accidentally going, well, intracranial.
That makes a terrifying amount of sense. Okay, now for the busiest part, the lateral wall.
Right. This is where you find those three bony shelves, the conchae: inferior, middle, and superior.
And under each one is a space, a meatus.
Correct. The inferior concha is actually its own separate bone, and beneath it, in the inferior meatus, is where your tear duct opens.
The nasolacrimal duct. That explains why your nose runs when you cry.
It does. But the real action, the operational hub, is in the middle meatus,
This is where we find the osteometal complex.
the heart of the nasal plumbing system. The middle turbinate itself is part of the ethmoid bone, and it can even be hollowed out with an air cell.
Which is a variant called a concha bullosa.
Right, an air-filled turbinate.
So, walk us through this osteometal complex. How do we picture it?
Okay, imagine a small funnel-shaped cleft. That's the ethmoidal infundibulum.
A funnel. Got it.
Now picture a very thin, hook-shaped sliver of bone forming the inside edge of that funnel. That's the uncinate process.
Okay, a funnel with a hook for a border.
Exactly. The opening behind that hook is the hiatus semilunaris, and just above that, there's a rounded bulge. That's the ethmoidal bulla, which is the largest of the anterior ethmoid air cells.
And all of that is packed into just a few millimeters.
It is. And this tiny complex area is where the maxillary sinus, the anterior ethmoid sinuses, and the frontal sinus all have to drain.
So any swelling, any blockage there?
It shuts everything down. A bit of inflammation can compromise clearance for 3 major sinus groups all at once. It's a massive functional burden on a tiny piece of real estate.
Let's talk about the lining itself, the mucosa. It's doing a huge job.
2 jobs, really. Most of the cavity is lined with respiratory epithelium.
This is the mucociliary escalator.
The ultimate internal conveyor belt. It's lined with tiny cilia that are constantly beating, moving a sheet of mucus backwards.
Trapping all the dust and particles you breathe in.
Everything. And it moves that mucus back into the throat at about 6 millimeters per minute, where you swallow it, and your stomach acid destroys the debris.
Happening right now. Constantly. That's amazing. What's the other type of mucosa?
The olfactory mucosa. It's just a small patch way up high in the olfactory cleft.
And this is where the olfactory receptor neurons live.
Yes, the actual nerve cells for smell. Their axons are what pass through that cribriform plate to the brain.
And these are special neurons, aren't they?
They are unique. They are continually lost and then replaced throughout your entire life, thanks to a population of basal stem cells. It's one of the only places in the adult nervous system where you see this constant regeneration.
We have to come back to that. But first, blood flow. The nose is famous for bleeding.
It's incredibly vascular. And that leads us straight to Little's area, or Kieselbach's plexus.
This is the source of most common nosebleeds.
It is. It's on the anterior part of the septum, and it's a spot where branches from 3 major arteries all come together and connect. It's a natural weak point.
Okay, that's the arterial side, but the veins have a darker story.
They do. The veins draining the external nose, an area sometimes called the danger triangle of the face, connect to the ophthalmic veins.
And those veins don't have any valve.
They're valveless, which means blood can flow in either direction.
And where can that backflow lead?
Straight back into the skull, into the cavernous sinus. It provides a potential, though rare, route for a facial infection to spread directly to the brain, causing a cavernous sinus thrombosis. It's a devastating complication.
That really puts things in perspective. Okay, let's move deeper to the perinatal sinuses themselves.
4 pairs: frontal, ethmoidal, sphenoidal, and maxillary. They're all air-filled cavities that open into the nose.
And they get bigger as we grow.
They do, a process called pneumatization. They're mostly rudimentary at birth.
Let's start with the biggest one, the maxillary sinus.
It's a pyramid shape inside your cheekbone. Its roof is the floor of your eye socket, and its floor is right up against the roots of your upper teeth.
And its drainage is a huge design flaw.
A huge challenge, yes. The opening, the ostium, is near the roof. So to drain, the cilia have to beat mucus uphill against gravity. If that escalator fails, fluid just pools at the bottom.
Then you have the ethmoidal sinuses, the labyrinth between the eyes.
It's a honeycomb of thin-walled cells. And the key vulnerability there is the medial wall of the orbit,
The lamina papyracea.
which literally means paper plate. It is paper-thin bone. It's a terrible barrier against infection, which is why a bad ethmoid sinusitis can spread into the orbit and threaten vision.
And the variations, like Haller cells, just make the surgery more complicated.
They do, but the deepest and highest risk sinus is the sphenoidal sinus, way back in the center of the skull.
This is the one surrounded by critical structures.
Yes, its walls can be incredibly thin, and right next to it, sometimes even bulging into it, are the optic nerve and the internal carotid artery.
That's terrifying.
And then there's the ultimate dangerous variant, the Onody cell.
What's that?
It's when a posterior ethmoid cell grows abnormally, wrapping itself around the optic nerve. A surgeon who doesn't identify it on a CT scan might mistake it for the sphenoid sinus.
And cause devastating direct injury to the optic nerve.
Exactly.
Wow. So the takeaway here is that you absolutely cannot assume a standard anatomy.
You can't. Anatomical variance is the norm, not the exception. In this whole region, every single patient has a unique map.
Which all comes back to that osteomedial complex. If it gets blocked by swelling or a variant, you get sinusitis.
And if that infection gets bad, it can spread through those thin, bony walls, the lamina papyracea to the orbit, the cribriform plate to the brain.
You've really painted a picture of how interconnected and high stakes this anatomy is.
And even for something like a severe nosebleed, a surgeon needs to know exactly where the sphenopalatine artery is to control it. The source even notes that if you accidentally sever the anterior ethmoidal artery, its stump can retract back into the orbit and cause an unstoppable bleed behind the eye.
It just underlines the need for that detailed 3D map we've been building.
It does.
So we've gone from the dynamic external valve all the way to the deep labyrinth and its neurovascular risks.
And as we wrap up, let's just circle back to that idea we touched on, the olfactory receptor neurons.
The ones that are constantly being replaced throughout life.
Yes, given that we have this ongoing natural neural regeneration happening right there in a mature adult,
Yeah.
what might that tell us?
What are the implications?
What implications might that continuous renewal process have for future treatments or maybe even early detection of degenerative neurological diseases? It's a really compelling thought.
It really is a unique window into neuroregeneration, a fascinating place to leave it. Thank you for joining us on this very deep dive into the anatomy of the nose and sinuses.